Mhm. Okay, perfect. So I imagine everyone on this webinar knows this, but just to underscore the truth, which is that, you know, the modern molecular biology and chemistry and medicine certainly have revolutionized the world in terms of the access that we have to interventions that prolong and enhance our lives, whether that's through cancer chemotherapy or immuno-oncology to organ transplants, dialysis, treatment for sepsis, surgery, and chronic diseases. None of these things is successful without a good antibiotic on board. And when I say good antibiotic, I primarily mean one that is effective against the bacteria that are causing or are likely to cause infections in these different populations. And you know, the trouble is, and I'm sure you know this, but you know, people have come to expect antibiotics to work and to be around almost like you expect your parents to be around and supportive of you. And no one really asks the question, what happens if it would? And so all of these advances would really not be possible without proper antibiotics. So I was asked to touch briefly on what it take a drug from what we would call perhaps, you know, early concept of drug discovery to development, regulatory approval, and then marketing. And so starting from left to right, you know, there's the basic research, and this is often done in the laboratory setting and often funded by international or national governments. And so this is basic research that often identifies the molecular target and provides paths to understand mechanism of action. Then there's the early discovery, which really comes from what we call hit to lead, and I'm sure you're all aware of this, but you know, where you have a molecule, and this is specific to therapeutics, although there's an analogy to preventatives as well, where you have something that works and against the bacteria, and you think you understand how it works, but it's early, but you have enough activity relationships to be able to be confident that you can optimize them. And then, you know, towards the drug. And then there's the preclinical stage, which really is about enhancing the dossier of the molecule to include, you know, efficacy measures, safety measures, to be able to prepare it on scale so that you can file a regulatory submission with the appropriate regulatory bodies and ultimately gain approval to commence studies in humans. And so then we move into the middle section here, which is the clinical development section. And that is usefully broken into 3 categories. Phase 1, and phase 1 is really all about safety. So they're not really looking to see efficacy here. It's with a small number of generally healthy human subjects, sometimes patients, if it's appropriate to do so. But what the regulators are looking for is a dose escalation up to and maybe beyond the dose that would be considered effective based on animal studies. Phase 2 then picks up from there and then builds on the story of efficacy. So now that you know what doses are safe and what doses are consistent with what animal models of infection tell you should work in humans, then, you know, let's do a study in a small number of patients. And so typically you're talking in the 50 to 100 category, and then you generally have a control arm as well to look at, does this drug actually work, or does this vaccine or other preventative actually work? And then you transition to phase 3, which is really then building upon that. These are typically global trials, they're very large. And the question is, in a large population, do these observations hold as well? If all of these things happen simultaneously, or not simultaneously, but sequentially, then you would be preparing to file a new drug application or equivalent document with a regulatory authority to gain approval, in this case, FDA approval, but again, any regulatory body approval to be used on the market. So I thought it might be important to highlight the difference between a lot of other drugs and antibiotics. And so most drugs, let's think about a cardiovascular agent, for instance. So, the patient is going to take the drug, whether it's an oral, therapeutic that he or she ingests, or whether it's an IV or an intramuscular injection or an inhalational drug, doesn't matter what the delivery is. But the patient gets the drug finds the target, the drug works. And antibiotics are a little different from that. So the patient receives the drug similarly. The drug finds the infected organ, hopefully, but then the drug has to not only get to the site of infection, but then get into the bacteria. So it's an exogenous target, which is a little different from many other areas. And then it has to not only get in, but learn the rules for staying in so that it's not ejected and therefore ineffective. And then the drug works. So there are some other rules that are important for engagement, but in the general sense, the approach is the same. Okay, so I thought it might be helpful. Maybe you've seen this a million times, maybe you haven't. But this is a timeline that usefully ends at 2000, and it usefully ends at 2000 for the story I'm going to tell you following the slides. But it's important to say that as early as the 1930s, antibiotics, of course, were introduced, and they were really miracle drugs. So all of a sudden, people weren't dying from infections, for which they didn't need to die. And then what happened between the 1930s and about the time that I was born is that you had introduction after introduction after introduction of a lot of very interesting and novel classes or enhancements on existing classes, where what I mean by enhancements is, gee, I've changed the structure of the molecule such that it has better penetration into gram-negative or gram-positive bacteria, or it seems more robust to resistance that's developing, or it has better safety than that molecule did, or it has bioavailability that is better than its predecessor. So many different ways to enhance existing classes or to bring forward new classes. And so, you go from your trimethoprim here to beta-lactams that come in, to phenylpropanoids. So these are things like chloramphenicol, polyketides. So these are your, tetracyclines, for instance. Then you have your macrolides, aminoglycosides, quinolones, glycopeptides, a lot of different classes and a lot of different representations within those classes of advancement. But then all of a sudden, there wasn't a whole lot that happened between 1962 and 2000. Other than minor modifications on existing drugs until 2000, when the first oxazolidinone called linezolid was launched. And this was pretty big because it was an IV oral antibiotic, so useful in many clinical situations, useful in many parts of the world because of the oral component of that. And, again, it targets the ribosome, which we talked about here earlier, the tetracyclines, the aminoglycosides, and macrolides, all target, but it does it with new chemistry and in different ways. And so that was pretty exciting. And so what I'm going to tell you next is the story of the little company that I helped to found that built on that success. And so in 2000, as I just mentioned, in April of 2000, the FDA, the Food and Drug Administration of the United States, approved linezolid, its trade name is Zyvox, for use. But then, and then the landmark publication about the foundational science that led to that discovery, excuse me, which was the elucidation of the structure of the ribosome and how antibiotics bound to and inhibit its function, was published. Pardon me. So then my former company, which we named CARB-X, was founded. And here you see in this picture on the left is Tom Stites. Tom was a professor of biochemistry and biophysics at Yale. And for this discovery in 2009, he won the Nobel Prize in Chemistry. His colleague, Peter Moore, who helped him to bring forward the solution of these structures. And the person on the right is a woman called Susan Proschauer, who was the founding chief executive of the company. But so then you see exactly a year from the launch of Zyvox or linezolid, clinical resistance started appearing to linezolid. And this was pretty concerning because here you have a new targeting a well-known mechanism of action, and here all of a sudden you're seeing resistance to it. And so that was kind of a problem. And then you saw it in a different pathogen. So the first pathogen was from the enterococci, and now you see it from the staphylococci. And so what we said was, well, gee, thanks to Tom Space and Peter Moore, we understand how all these antibiotics bind to their targets, and we understand the directions in which we could change this molecule or modify it in order to overcome resistance and restore the activity of linezolid. And so that's what we sent off to do. We received some funding for it in early 2002, and we built a company. And this was our tagline. So we were going to exploit the ribosome to rapidly design and develop next generation antibiotics active against drug-resistant bacteria. And our story that we told investors, and you always tell a story to investors, is that because we were starting with structures and known antibiotics, we were starting really in lead optimization, and it would be from here to a clinical start in first-in-human, no more than 5 years, because we know the target, we understand the chemistry, we should be able to do this. And so we did, actually, and here's the story of how we did it. And so from the structures, we knew that linezolid was adjacent to an antibiotic called anisomycin, and they were tethered. Actually, we could tether them actually because they bound in different spaces by just some chemistry, and this was proof of concept. And once we understood that we could bring these two spaces together, then we started doing lead optimization. And our first clinical candidate came not that long after that. This was something called Ribex 1284, and we actually put that into first in humans in 2005. So again, 2002 to 2005, so that's a 3-year clock, which is actually well within the time frame that we projected. But just as you do, we knew that, not always is the first molecule that you create the best, and so we did a backup program. And here you see this new molecule, Ribex 1741, which came right between the end of 2003 and the beginning of 2004. And we put that also into a first-in-human. And the question was, which of these molecules, given safety and properties, was going to be the one, hopefully the one, that we would take forward into clinical trials. And so once we saw the data between the two of them, we thought 1741 was the better molecule to move forward. We named it Ridazolid, and then we launched 2 phase 2 clinical trials, both in 2017. So this was great. We were very excited. We have this new molecule that has expanded spectrum. It overcomes resistant bugs. This is really great news. But then at the time, this was happening. So let me go back. We did the first in human. We started in 2006. We started these clinical trials in 2007. But in June of 2006, something really disturbing was happening. And this was that an antibiotic that was launched by a company that was then called Aventis and now is known as Sanofi. They launched an antibiotic called Ketec, which was in the general class of macrolides. So think about azithromycin. These are very important community drugs. They're used for sinusitis, community pneumonia, and many other uses as well. And so here they have the next generation of this, very exciting. But it wasn't too long after the launch that it turned out that there were reports of idiosyncratic liver tox. And so this was a big concern. And here you see an article from the New York Times where the FDA was actually called upon, by Congress and by members in the Office of Drug Safety, and asking really, what are you doing here? You're giving unsafe antibiotics to our children. So pretty sensational, but pretty concerning. And there were other articles. So this is an article from the Washington Post, really underscoring the important point, which is that we have this antibiotic. We're not sure how it works, but here we have a really fatal flaw in terms of liver toxicity for something that should be able to be sprinkled about the community and used. So again, really concerning right at the time when we were starting a clinical trial with a new antibiotic. And I could go on, but I think the point here with this screenshot is to go right to here, which is to say that it became really obvious that the way that we developed antibiotics, particularly antibiotics that were to be used in the clinic, was going to have to change. And so that was actually very difficult, okay? And so the problem with it was that all of a sudden the FDA said, whoa, we really need to change the way we develop these antibiotics. And so they went away and they said, we're going to create new guidelines. But we inferred from that whatever happens here, probably the best plan is to go into really high-risk patients in the hospital with, bona fide, challenging infections, demonstrate the utility of the drug, and then maybe be used later in the community. And so Rede's lid shifted from what was going to be a focus on community-acquired pneumonia and acute skin infections to more serious infections in the hospital. And so we had to build an IV arm. We also had a fluoroquinolone, different mechanism of action that we brought in. This was a community drug to be the replacement of levofloxacin. But because of these challenges in the FDA, we knew we needed to pivot towards the hospital as well. So we needed an IV form, and we needed to really demonstrate that we could cover MRSA in challenging hospital situations. And then we also launched a new discovery program focused on escape pathogens. And so just when we did that, okay, we brought in that second antibiotic, delafloxacin, fluoroquinolone. We did do the IV work just like we said we would. We completed a phase 2 with that IV form. We underscored the MRSA advantage of this quinolone, and then boom. In 2010, the FDA released new guidelines, and they had objective endpoints, which is great, but very different from what others had done before. And we were just ready to start a phase 3 trial. So we had to rethink about this. We weren't sure because there were no data on existing antibiotics and how they performed. And so instead of jumping into phase 3, which would be the natural extension of what you would typically do, we did a second phase 2 study where we looked at these new objective endpoints the FDA was suggesting, and we compared our drug to linezolid and vancomycin, which were really the two standards of care at the time, very different classes, very different mechanisms, to ask, how do they perform against these new endpoints, and how do we perform? And so while this was all happening, you can see here, and so again, that Aventis problem happened around here. Things were already declining, and then they declined more. And so here we have a situation where we're not having new antibiotics come to market. The products that we've had have been stalled for a while. They're just going to get started again. And so it's kind of a bad situation. But the FDA, and certainly encouraged by many, recognized this problem. And so in 2012, they did enact something called the GAIN Act, which stands for Generate Antibiotic Incentives Now. And the idea here was basically to say, we recognize that there's been a multi-year period of time where product developers have not been able to advance antibiotics because we were looking at new endpoints. And so they said, okay, we recognize this, we're going to help you. Okay, and so number one, we're going to have new ways of developing these innovative products so that we can get them to market and feel good about bringing them to market. Number two, though we recognize, and importantly, we recognize that this period of waiting for us to come up with these new endpoints just ticks away your time clock, your patent clock. And so we're going to give you an additional 5 years of exclusivity. And then we're also going to engage with you to bring you to priority review. So all really good stuff. And so, we definitely applied for this new designation for both of our products. And in fact, we're the first to receive them. And so then move forward to 2017, really exciting day. Okay, delafloxacin, which was the trade name for the Accelerator, which was the trade delafloxacin or fluoroquinolone, was approved by the FDA. So very exciting. Okay, yes.
Sorry for the disruption. Maybe you can stop sharing your video to improve the bandwidth a bit, if you don't mind, please.
Oh, sure, absolutely.
Okay, thanks.
Okay, is that better?
Yes, it's better.
Okay. So our antibiotic was approved, and that should be a very exciting day, and it was. But then what happened, not too long after, was that many bad things happened, many bad news happened, but I'm going to focus you here on the bottom right, which was our company, which had been renamed Melinta Therapeutics, filed for bankruptcy. Well, it was actually, earlier than this, but it was in the end of 2019, December of 2019. So 2 years after we were approved by the FDA. So that's, really, really pretty terrible in terms of being able to finally come through with new regulatory guidance and new incentives in terms of patent life, and then to realize that it costs more to put that drug on the market than in fact it would bring back to the company. So, pretty terrible story, and we're not alone. So you can see here, there's a company called Tetraphase that launched an antibiotic in the same time frame, and then just couldn't afford to keep it and sold it. Novartis had a very interesting monobactam, so gram-negative targeting drug, but recognized that they were going to have challenges too. And Novartis, being a big company, just said, we're not going to do this anymore. And so they stopped doing antibiotic development. GlaxoSmithKline looked at that and said, well, heck, we're not going to do that either. And there were many other companies. Achaogen is another example. So these were very grim times. Okay, so the US government initially, and then joined by other funders, recognized these grim times. And so they created something called the Combating Antimicrobial Resistance Accelerator, CARB-X. And the group that they chose to run this is our group, which is domiciled at Boston University. And the remit was very simple. We understand that the drug discovery and development world is challenging. We understand that the economic situation isn't great on the other side, but we also recognize that the toll on human health and the challenges that a poor antibiotic environment presents to all of these miracles of modern medicine is huge. And so we need to find a way to continue to build the pipeline of innovative ideas and products so that when we fix these other things, we have working antibiotics. So that was the whole premise. And so in 2016, CARB-X received, and then over the period of time between 2016 and 2022, $500 million to build an organization and accelerate innovation addressing the global rise of antibiotic resistance. We didn't care where the science came from, big company, small company, any place in the world, we wanted to hear about it. I should say that just recently we have been reinvigorated by our two biggest funders, the US government through BARDA and ASPR, and the Wellcome Trust. So we give non-dilutive funding. That means, there's no equity stake. We have no IP rights. We support and fund, very simply, innovations in the areas of treatment, prevention, and diagnosis, all focused on bacterial infections. There's a small cost share that our product developers are required to give, and we often help them to find funders that can bridge that gap. We are focused and continually focused not only on the pathogens that cause the most burden, but on the infectious syndromes with the highest mortality rates attributable and associated with AMR. And of course, this becomes much easier to plant a flag on now that we have the so-called Graham paper that was published in the Lancet in the first quarter of this year. And so here are some statistics down in the chevron. So we have had a total of 8 funding calls over those 5 years and received over 1,000 expressions of interest, which is a very simple application at the beginning to understand whether you're responsive to our calls. Of those, we funded less than 10%, so 92 projects have been funded and supported by CARB-X. Today, there are 45 active projects. But then in terms of success metrics, let's look at those in the next chevron. So we have today supported 11 first-in-human starts for treatment and prevention programs, so early clinical starts, and 4 equivalent projects at that stage in diagnostics in the area called validation and verification. And then when you look at what happens when you leave our remit, which begins from not early basic research, but hit the lead all the way through to a demonstration of safety in humans. From there, we have 2 products, 1 treatment and 1 prevention, that have been embraced by advanced development partners. They are in phase 2 and phase 3 studies today. And then 2 diagnostics that are on market in Europe and have filed with the FDA. So I think, the point of the slide is that we are filling this gap, and we're continuing to build on this to deliver products to advanced developers. So again, we have innovative products when we need them. At the bottom, I'll just highlight again that we are funded by many different groups. So the Assistant Secretary for Preparedness and Response, the ASPR and BARDA, that's the US government component, the Wellcome Trust. I'm going to skip over the NIH for a minute here, but the UK aid, so this is the UK government, this is the German government, and then we have the Bill and Melinda Gates Foundation. Finally, the National Institutes of Health through the National Institutes of Allergy and Infectious Diseases do not support us financially in the direct sense, but do provide what they call preclinical services, and now they're expanding that to diagnostics that is free to our product developers. So while it's not funding to do things, it's in-kind work to advance the product. So here are the 92 companies. I'm not going to go through them all, but just to highlight for you that there are a lot of different names and phases and science and targets and projects that fall under every one of these names. So as I said, our portfolio is responsive to the Graham paper. So this is actually a stylized version of figure 2 in that paper, where on the x-axis you have the numbers of deaths, and on the y-axis you have the bacterial syndromes that are associated with those deaths. And so, for instance, if I start at the top, lower respiratory tract infections, bloodstream infections, interabdominal, urinary tract infections, tuberculosis, skin infections, brain infections, typhoid, diarrhea, cardiac, bone, and gonorrhea. Now, gonorrhea, of course, was not highlighted in the Graham paper because of mortality, but there is significant morbidity in a high-risk population. And so the bars extending from them, the light gray indicate deaths that are associated with antibacterial resistance, or AMR. And then the gray bars are deaths directly attributable to resistance. And so you can see these are pretty big numbers. Anyway, to the far right, all these red dots are meant to indicate of the 92 projects in portfolio where our projects have emphasized focus. And so you see that we are very nicely distributed with heavy emphasis at the high end there of the highest burden and highest mortality, so therefore the highest unmet medical needs. I'm not going to spend a lot of time on this slide except to say that these wheels represent our treatment portfolio. On the left is a representation of the types of mechanisms in the traditional small molecule antibiotic realm. And so you see many different mechanisms, and that's important because you need to present the bacteria with a lot of different ways that it has to think about you in order to overcome you. On the right is the wheel of projects, almost as many as the direct acting small molecule group, which is where heritage is from. But now you see a lot of different modalities. And so you have antivirulence, antibody-based, immune-directing, protein therapeutics, which are often products of bacteriophage, engineered bacteriophage, potentiators, and antisense. So a lot of different modalities coming to the table, hopefully to address AMR. And then just to complete it, we do have a prevention portfolio because we view, just like you think about COVID, we view prevention as critical, diagnosis is critical, and treatment as extremely important once you understand what you have. And so here, smaller overall prevention portfolio, but you see we have vaccine approaches, live biotherapeutics, engineered bacteriophage, and so we took bets on phage, whether it be treatment or prevention, to understand where they played best, and then antibody-based programs and small molecule-based programs. And then on the right, this is our diagnostics portfolio, and it's just to show that it focuses on many key syndromes, which our treatment and prevention portfolio are going for. And the reason that we do that is when you think about conducting clinical trials, particularly if you have a product that is narrowly focused, you need to be able to identify the patients where you're going to demonstrate best success and therefore get the label that you want so that you can treat the people in need. And so that's our diagnostics portfolio. Now, we are not a direct funder. We receive money from, as I highlighted on the last slide, a lot of different funding agencies, but they can give out money better than we can. Why they support us is not only to give money to product developers to advance their programs, but also to fund them or support them both scientifically and from a business perspective, because most of our companies are 5 to 10 people in a company. They're great at the foundational science. They're not great at translating that into drug development programs. Part of how we do this is from a global accelerator network. And you can see here on the map several groups that are currently in our global accelerator network. And they engage with not only product developers in portfolio, but potential product developers to help them either prepare applications or move programs forward, or help them address laser-specific questions. And so that's part of our acceleration strategy. But again, we also have a subject matter expert pool, about 120 subject matter experts that really represent the breadth and depth of expertise that groups need to take programs from an idea through a product. This is given completely free, and it's just to help these companies really get it done in an efficient and effective way. I highlight here the preclinical services from NIAID, and again, these are services free to the product developers that help them ask key questions that the government will pay for to advance the product. Internally at CARB-X, we've started a program called Portfolio Acceleration Tools, where we identify problems that more than one product developer is facing, and then we commission a unit of work to address these questions. We then make the data available to the ecosystem, and hopefully that will help them to de-risk their assets. And then finally, we revisit both internally and also with external potential downstream partners like BARDA or the AMR Action Fund or pharmaceutical companies We engage with them in a review of the target product profiles of the products we support, as well as clinical trial designs, because what we want to do is not only advance things that we find meaningful scientifically, but also things that advanced product developers will take on to bring them to patients. And so this is an array of projects, and I'm not going to highlight them all, but just to say that we recognize in a portfolio of 92 programs, and then looking out at the ecosystem, where there are challenges that we can help people address. And so again, we're getting very involved in commissioning some research to help them understand this. Now, of course, and certainly I think you will know this better than most, but the grant paper and others certainly shone a very bright light on where the death toll is most painful, and it is certainly in low middle income countries. And you can see here in the graphic, based on region or geographic region, where global deaths are most prominent. And that's obviously a big concern to us, because it's not in the high income countries where a lot of our companies sit. In addition to which, it's very painful to note from the grant paper and also from the Barnard study and the CHAMPS database that certainly a disproportionate number of these deaths are coming to the certainly youngest and most fragile among us. And so I highlight that to say that CARB-X is very focused not only on bringing antibiotic and antibacterial solutions to market, but also doing so in a responsible way. And so we do have and require all of our product developers to engage in a stewardship and access plan. Now, of course, they pledge to it when they come in portfolio, but it becomes meaningful at a time when they need to transition into late clinical stage programs and need to think about how to make these drugs available. I want to say one final note about our diagnostics portfolio. So we have tailored it to be what we call aligned by design. So first of all, I have to say that maybe a bright spot of SARS-CoV-2 is that we have installed bases of diagnostics all around the world at different levels of the healthcare system. And so this teaches us that you can provide products that can, both ID and then more recently highlight, where you have variants in the COVID-2 vernacular. So there's that opportunity. We focus on this because we want to use these diagnostics in clinical trials for the development of therapeutics or preventatives, so that we enroll the most important patient populations. And then, certainly for both, but particularly for therapeutics, once you're successful, you need to have strategy where the pharmacy and the hospitals understand how your product is used and that they want to use that. And that's another role where diagnostics becomes very important. So I want to end by saying that our organization, CARB-X, sits in the middle of a chain of innovation supporters, and every one of these links of the chain is absolutely critical to solving the problem, or not solving the problem. AMR is a fact of life, but staying ahead of it and having meaningful products that prevent, diagnose, and treat bacterial infections, particularly those caused by resistant infections, is really important. And so to the left of us, so upstream from us, is really the focus on basic research. And this is often done by your government bodies here in the US. That's the National Institutes of Allergy and Infectious Diseases. I've mentioned them originally. But there are a bunch of other groups. So there's JPI-AMR, AMED, BMBF, the German government, the MRC, and BIREC. So a lot of different groups here. We play in the middle section. We play along often with Nova Repair. Nova Repair is a dilutive funding mechanism, but in fact, they have co-funded many of the products in our portfolio, and then there have been other efforts as well. But we need downstream partners, so people to take these products from where we take them through to approval and licensure. And so those are groups like BARDA who fund us, the AMR Action Fund, which I'm sure you've heard about, but this is a $1 billion fund created by the biggest pharmaceutical companies and foundations, take products through advanced development and onto the market. HERA is forming still, and so we await their plans, but in the meantime, I'll say that the thought is that they are the European equivalent of BARDA. Then you have GARD-P, and this is a group that is really focused on a number of initiatives, but they do late-stage clinical studies, and they are active today in supporting the late-stage clinical development of a potentially novel class of antibiotics for gonorrhea. And so they are advancing in the space. They also have an initiative called Secure, which is to find a way to provide access for antibiotics, for instance, on the essential medicines list or other effective antibiotics, and to ensure their availability in all regions of the world. So a lot of different endpoints there, all very important along the chain. And I just want to say, I'll come back to what I said at the beginning, which is that really antibiotics are maybe not the most important drug class, although I'd argue maybe they are, just because of the demand on them for use in all of these treatment settings. And I think the bottom line here is that, we need a way to maintain these antibiotics in the face of what are poor economics, okay? And so we have to think about a different strategy. And so the idea that's often floated, and this is why this image is here, is that antibiotics are the fire extinguishers of medicine. So John Rex, if you've heard from him, says it all the time, which is that everybody has a fire extinguisher in his or her house, and you have it there in case you need it. You almost never need it, and usually by the time you need it, it needs to be refilled. That's a different topic, but the concept certainly works. And so again, most antibiotics are going to be held in reserve, which is a disincentive. Not everybody is sick all the time. That's also a problem. You have ways that we pay for hospital antibiotics as part of a broader treatment group, so that depresses what you can possibly make from them. Diagnostic devices need to be better to really help people understand how and when to use them. And so the solution here is to pay for protection in advance, like you do for fire extinguishers. You don't know you do, but you do through other means. And that is where the Pasteur Act comes in. And this is an act really focused on valuing appropriately antibiotics, where then the company agrees not to build the sales force to market them. Oops. And so, this is something that today has both sides of the house support. The idea is to have a fund so that antibiotics or other products that certainly meet a minimal threshold in terms of treating, preventing, or diagnosing challenging infections related by gram-negative bacteria or antibiotic-resistant bacteria can be used. So very important, moving through Congress, and we're hopeful that it will be supported. And so with that, I'd like to end saying that we think the future here is positive. We're continuing to support programs so that we have these solutions when we need them. And we're very active on the policy front, hoping to get initiatives like the Pasteur Act approved. And so with that, I'll stop and love to address any questions you have.
Thanks so much, Dr. Erin, for the wonderful presentation, and also for taking us through your journey, right from Rebex, which transitioned to Melinta, and how you had direct, experience in all these, the challenge that we are currently facing with antibiotics. So I'll just request, maybe if any of us has a question, you can share in the Q&A section. See, we have a few minutes. We can just address some of them. So I'll start with a question maybe from Asani. So it's not very much related to the topic, but she was just inquiring why we see that, especially from the GRAM study that you shared, that the respiratory tract infections quite have a higher mortality compared to other diseases. Thank you.
Yeah, I mean, it's a good question. I don't know that necessarily, the bacteria modify or mutate any differently in respiratory infections than others, but I think they're just more prevalent. And, I think, you've probably seen, but even recently there was a paper published which highlighted the number of secondary bacterial respiratory infections that patients had after recovering from COVID. Because often, you're in this immunocompromised state from having the COVID infection, or maybe you have a viral lung infection. And often that creates a very good environment for bacteria to move in. And so I think that's just part of it.
Thank you. Thanks so much. Then we can transition to another question. And this is from Mwitupa. And she noticed that the partners that you shared, there were no maybe partners, not just the funders, but also the Global Accelerator Network from South America, Australia, and Africa. And maybe to just add on to the question, maybe for these areas, especially maybe in Africa, where I come from, you find that there is not much research and development that happens. So are there maybe efforts that can, drive towards, improving the capacity and infrastructure just to encourage also pharmaceutical companies in the African setting, or even South America or Australia, to take up on this research and development process? Thank you.
Yeah, I'm really glad you noticed that, actually. So I should say that we have an acceleration strategy that goes beyond those partners that I highlighted, but it is an important observation that we have many geographic holes in that accelerator network. And so I should say that the chief scientist of CARB-X, my colleague Richard Alm, he's Australian by background, and he has been living actually in Australia again for about the last 9 months. And part of being there is to help us build the network out in Australia so that we can benefit from what we know is a very healthy ecosystem there, and also help them to understand how to be responsive to CARB-X. So that's an example. We are very aware of organizations and the research going on in South Africa and Africa, and we are active in trying to find ways to boost the awareness of CARB-X and the opportunities that may be presented therein. And I want to highlight here, on that slide of the globe that you saw, one of the groups that I highlighted there was a group in India called CCAMP. And I can tell you that before we engaged CCAMP, we had very few, in fact, extremely few proposals from India. And then after we engaged CCAMP and we helped them in terms of their communications within India, and then we built some webinars with them to train people and make them aware of both the challenges and the opportunities and how they might tune their science. We increased dramatically the number of proposals that we received from India. And so we think this is a model that we'd like to embrace in CARB-X 2.0 for other geographies, including, of course, South Africa. But then I should end on saying, as I mentioned at the top of this, that the Global Accelerator Network is just one component of our acceleration strategy. The rest includes subject matter experts from around the world. And actually, we have a number of them from South Africa and Africa more broadly, who advise us on everything from regulatory strategy, clinical trial design, chemistry, chemistry, manufacturing and controls, microbiology. And so, being able to engage these subject matter experts and make them available to our product developers is something we're also very active in. So again, a lot of different ways to engage these networks, but certainly I want to emphasize that we understand and want to build on our successes to bring more regions and geographies into our program.
Thank you so much for that really elaborative response, and we appreciate the efforts that CARB-X is putting in place to bring our regions on board. So I'll just want to take one question from the Q&A, and then maybe we can take one hand that is raised, then I think we can close there because of the time. And this question is from Dengue, and Dengue says, antimicrobial prescription works best when supported by correct diagnosis. In most cases, especially in low and middle income countries, due to lack of relevant diagnostic resources or ignorance, this is not done. What are some of the mechanisms that can be employed to enhance diagnosis-based antimicrobial prescriptions? And maybe to add on to this question, are there some targeted calls, or maybe do you have some efforts that are driven towards, accelerating the development of maybe rapid diagnostic tests? Thank you. Over to you.
Sure. Yeah. So I think, again, we completely recognize this, which is why we do invest in diagnostics. And that's part of our pivot to what we call our Align by Design strategy, which is that we've noticed there have been a few pharmaceutical companies that have tried to develop antibiotics that were pretty single pathogen focused in scope. And so without a diagnostic, they would have to screen hundreds, maybe thousands of patients to find some of these antibiotics. And so we've really focused our approach on bringing in diagnostic programs that can efficiently help them do clinical trial enrollment, but then on the back end also help them with uptake. So we recognize this, and we do it in one of three ways. So if we have a company in portfolio that is a year away from clinical trials and they are a pathogen specific product, or they have a very special patient population, then we will look within our analysis of the worldwide diagnostic landscape and ask, are there products or programs that could actually help this program? And if there are, then we do matchmaking, introduce them, hope they make a pilot study together, and if they do, we'll often fund that. And then, from there, then we look to, okay, so we're able to help the clinical trials, but now we have this asset. How do we help the regulators and others downstream from that, pharmacies in particular, understand the value of this product and how to use it? When on phase, it would seem that maybe other things could be used. And again, that's where the diagnostic really comes in to highlight what you have and why you need this new drug. And so that's really our approach to building new diagnostics. In the ideal case, these would be new interesting assays for different syndromes and AMR and AST that would build on existing platforms. We're so thankful to have so many of them after COVID, but also we are engaged in supporting advanced development where necessary.
Thank you so much. And maybe we can just take one more question from Obino Tai, then I think we can close there. Maybe Obino, I see they had raised their hand. Are you able to hear?
Yeah, I can hear. Thanks so much, Daniel. I never wanted to type this question. I really wanted just to ask it so that people can hear it. So my name is Sabino Tai, working with the Ministry of Health, specifically in a county called Vihiga. I'm a clinical officer. So I've seen some intervention on AMR, and most of the time we are really targeting the healthcare workers. But for me, I feel that what is being done at the community level? Because most of the time we see when clients come to the hospitals, majority have taken these antibiotics. Before, maybe when it fails, that's when they come to the hospital. So is there anything that maybe this company is doing at the community level? Because I feel if we don't address AMR at the community level, we will not be able to fight this AMR, even if we produce other antibiotics. And personally, me and my friend whom I think is in this webinar, we have started an initiative called AMR Now. Maybe people can like it on Twitter, AMR Now, and we are trying, but our target we want to do at the community level. So maybe is there an initiative at the community level? Thank you so much.
You know what? Thank you. That is an excellent point. And you know, I probably didn't emphasize it enough, but when I was describing my company's journey, my former company's journey, you know, initially when we started, we were very focused on creating the next generation of new community-based antibiotics. But then that path became very challenged for the reasons that I described. And then, of course, from 2010, when ceftaroline was introduced, a new IV cephalosporin for MRSA, and then the next many antibiotics that were introduced were all for MRSA, and that's rightfully so, because that was the pathogen, you know, of most interest in the early 2000s. But you know, there's this recognition that, okay, we've spent so much time focusing on MRSA that all of a sudden these gram-negative pathogens are coming up. And of course, though you can see them sometimes in the community, they often cause nosocomial infection. And so the shift really went towards, you know, focusing on nosocomial infections. And CARB-X, I will say, in focusing in the first 5 years on the WHO and CDC priority list, you know, went that way, and that's not wrong, okay? But in the meantime, and we did a strategic review in 2020, and, you know, every physician that you ask, what is the next MRSA? Something like 80% of them would say MRSA. And not because we don't have a number of high quality solutions for AMR, but because they don't play to all levels of the healthcare system, and they all don't have the performance characteristics that patients need. And so this year, just last week, actually a week ago today, we launched our first, we launched a 3 themes for which we will accept applications for funding in basically between now and next year. And 2 of them really recognize this. So the first of which was a call for oral therapeutics. Okay, so there's one element there. And then those oral therapeutics could be responsive to a number of target product profiles, 2 of which were step down, or are step down, you know, so IV in the hospital, step it down to community. But one of which was focused on, you know, infections primarily caused by gram-positive agents. And there, again, the focus is really on community diseases. And we feel like, you know, it's appropriate to not wait 10 or 20 years till you have a problem, but try to remember that these things are cyclical. Likewise, with diagnostics, we also, the third theme that we had is focused on diagnostics, whether that's treatment, prevention, or, gonorrhea, whether that's treatment, prevention, or diagnosis. We want products to focus on gonorrhea. And of course, the point there is there's only one drug that works, not drug class, but drug that uniformly works, and that's ceftriaxone. And everybody worries that resistance will erode the performance of that drug. But being able to identify what patients have and whether it's resistant is really critical. And this is going to occur largely at the lower levels of the healthcare system. So we get all that. And then I guess the final thing I'll say is with diagnostics, we've been very clear that anything you bring us needs to play, depending on the infection, at different levels of the healthcare system. And that means the technology as well. So we're aware of this, and we're hoping to do a good job at it, but I think it's a work in progress.
Okay, thank you so much. And I think maybe on your last slide, I saw your email. Maybe I'm reaching out to you so that I can ask some more questions. Thank you so much.
Absolutely. Yeah, please do. I'm just very grateful for the time and would love to interact with you.
Thank you so much for that session. I think due to time, we have recorded the other questions that were shared in the Q&A. Maybe Colonel Kano, if that's the same question that you shared in the chat, we also recorded it. And I think we'll forward them to Dr. Erin so that maybe when she has some time, she can also address them. At this juncture, I'll just have to thank us all who have made it to this session. We do appreciate that you prioritized some time and came to learn more about drug research and development, in particular to antibiotics and other therapeutic interventions that CARB-X is supporting. And I would also love to thank Dr. Erin for taking us through, and also in absentia at the CARB-X team, and especially Robin for the coordination of this session. Thanks so much, everyone. And maybe Dr. Erin, maybe you can share some final remarks as we close up. Thank you.
Yeah, no, again, I just would like to thank you very much for the invitation. And, you know, I sense you appreciate, as we do, just how important our work is and others to bring forward and continue to bring forward antimicrobial solutions. It's not going to come from one place or one group. Or even one pillar of the research we support. And so we need to do it, and we'd really love your partnership in doing so.
Okay, thanks so much. And thank you everyone for attending this session. And I wish you a wonderful day and wonderful evening for us all. Thank you and bye-bye.
Thank you. Goodbye.